Hey everyone, Andrew here from a Tale of Two Hygienists podcast. Yes, you are on the right feed, but no, this is not a normal show. I wanted to let you know right now that what you are about to hear is not suitable for work. It is likely also not appropriate for children. If you are sensitive to racy topics, go ahead and hit that delete button right now. You might not like this episode. But now that you've been warned, please welcome to a special RDH RANT Takeover episode with Heather, Anna, and Liz.
Everyone, and welcome to another episode of RDH RANT Takeover. I am your host, Anna, and joining me today are the usual suspects, Heather and Liz. Guys, say hi.
Hello.
Hi. So lately, I've noticed a plethora of posts in various hygiene groups and basically asking some outdated information and outdated shit. And each time I'm like, why are you still doing that?
Why are you doing that?
Yeah, why are you still following old protocols? So we figured that would be a good subject to discuss today and why old habits die hard.
It makes me wonder if people take CE. Indiana has one of the lowest number of credits you have to take. Every 2 years, we're 19.
Yeah, we have every 3 years, and I think it's like 30 something. I don't even know. 32 maybe. I don't even know. But yeah.
So it just makes me wonder if these people take CE, and if they do, what CEs are you taking? And I think that's part of it too, is because we're not all taking the same CE. You know what I mean?
Yeah.
So I may know the new protocol on XYZ, but I didn't take the new perio staging and grading until this year, even though I worked in perio. I never had to do that because the doctor did it.
Yeah, that's one of the ones I'm having a hard time with, but that's a whole different subject, I guess. But basically old habits die hard, but let's get with the times, people, and let's start doing what we're supposed to be doing, right? So let's dive right in. What do you think is
the one thing?
Yeah.
What's the one thing you think that people do that they need to stop?
Lately, the one that I've seen the most that I find alarming is, and it's actually funny because every time I'll always comment, there's no, that's outdated. And Liz actually commented underneath mine and was like, why does this subject keep coming up? And it's using the ultrasonic. When someone has a pacemaker, can you use your ultrasonic?
Yes. Mm-hmm.
And it's like, yes, unless you have a DeLorean and you go back to 1995 at 1.21 gigawatts. Yeah, you have like that's old protocol. Yeah. So, Liz, what do you have from the ADA regarding that subject?
This isn't from the ADA, and this is actually the only topic that I didn't put a citation on, but I kind of had one built in. In 2022, the guideline from the British Heart Rhythm Society said that you need to keep the device 6 inches away, talking about ultrasonic scalers, apex locators, and other dental devices. Keep it at least 6 inches away from the pacemaker, and you're good.
Yeah, and that's every
in
op
20
is
in 2020, most dental instruments are safe and compatible for use with routine dental procedures as long as you're maintaining an appropriate distance away. So we've always heard, it's fine, they're shielded, just don't drape the cord over. And don't, I guess for electro-surgical devices, those have a higher risk, so they're not supposed to wave those around the patient's body. I don't know if they're What the hell is that? Some sort of probably something that oral surgeons use.
We don't know.
Yeah.
I don't know what that is.
Nothing that has to do with us.
Yeah.
So don't be draping the ultrasonic cord and don't wave it around their chest area, which I don't know why you would do that anyway.
Yeah, and then also, do you remember back in the day, I graduated a long time ago, I graduated in 2001, when this was still one of the protocols, but you'd have to put a sign on the ultrasonic, the thing that the jiggler that you put your dirty instruments in, and that said, pacemaker, do not use. Every time a patient was in the office, and there's still offices that do this. And I'm like, why? Here's the thing with this. If you really want to feel comfortable with using your ultrasonic scaler on someone who has a pacemaker, ask them for their card, call the number on the back of the card. You'll get your answer in 3 minutes and you'll be told it's perfectly safe.
Yes, they are shielded.
So is there a difference between, say, a Cavitron and we have a piezo?
Yes, there is a difference. actually.
I mean, I know there's a difference, but for the pacemaker.
Yeah, for the pacemaker, it says piezoelectric dental scalers may be safer than magneto-restrictive models.
Yeah.
Okay.
But
That's
it's
what
good.
it says.
But either
but
one,
neither of them pose a
yeah.
threat. So
Yeah.
either one's fine.
Okay.
You know, but I've in these posts sometimes get into heated debates about, well, I had a patient that I called and they told me, and I'm always like, what's the model number of that pacemaker? I want to know. Like, I need, you know, like, tell me. And no one has yet to answer that question. So I'm calling bullshit. I don't believe it. And that's that. So that's how I feel about that. Because no one has ever answered that question. As soon as you present that question, they're like, I don't know. Yeah, okay, sure.
Putting pacemakers to bed. You do not need to take any special precautions anymore. You don't need to call. You can use them. It's fine. Just don't drape the cord over the patient.
And also, don't call the cardiologist. The cardiologist doesn't even know. Just call the company that makes the pacemaker that's on the back of the card to get your information if you really want to feel comfortable.
Yeah. And going along with that, another one that we see often, and I think this is a huge carryover from school, and I think that that's where a lot of this comes from, is we learn something in school, and it is absolutely beat into our heads. And so we have, I mean, it's just in there, and so we have a hard time moving on past that, is heart attacks.
Oh, God.
Oh, you have to wait 6 months after a heart attack. And that used to be the American Heart Association's guidelines.
But
they
that
recommended
was their guideline, not for like prophies. That was their guideline for anesthesia. And it just carried over into the prophy portion. From my understanding, it was about anesthesia, like using, general anesthesia, local anesthesia, things like that. But for a prophy or perio maintenance, there never was really like a set forth protocol. And I think that just carried over from there.
What I took this from was from today's RDH, an article written in 2023 by Brooke Sargent. And I don't know if Brooke is in our group or not.
Yeah.
But it said, and it didn't specify, it just was talking about in general dental procedures, that it used to be 6 months. Yeah, avoiding dental procedures was recommended for 6 months. However, due to advances in cardiac management, the 6-month waiting period is no longer recommended, and now it is a 6-week post-infarction time frame.
Yeah.
Yeah, that's what I read.
Yeah.
And the funny thing about that is periodontal disease is linked to heart disease, right?
Right.
So how does it make sense to like, oh, no, we're going to make you wait another 6 months to get that bacteria that may have caused your heart attack, but we're going to leave it there for another 6 months? It like literally makes no sense from a logical standpoint.
I think the logic there, and I could be wrong, is that you're in their subgingival where that really bad bacteria lives, that anaerobic periodontal, and you're in there cleaning, probing, so you could get that, and then they can get that into their bloodstream.
No, I don't think it's that.
I think that's the thinking.
No, it's not that.
No, that's something we're going to cover later with the endocarditis.
All right.
Yeah.
Okay, then I don't know what the hell I'm talking about.
They say 6 months after a heart attack, you're more at risk for having another heart attack. So, but that's walking in the street. That's going to the supermarket. You're just more at risk in general. You know, and sometimes in the dental setting, maybe like our anxieties are a little higher. So maybe that can exasperate it, I guess. But at the same point, the benefit doesn't outweigh the risk of leaving that bacteria there.
And I guess I also want to put this disclaimer out there that we are not doctors.
Yes.
No. We just play them on TV. No. We're just reading the research that's out there.
Yes.
So I urge, and what I do in my office is if we have any question, any concern, any doubt, we contact the patient's doctor.
Yes.
Yeah.
And get a medical clearance.
Yes.
Pretty much all of this says, everything that I looked up, all the guidelines, everything I pulled from the ADA website, everything, especially if somebody is medically compromised, immunocompromised, is complex, was that medically complex to consult their physician, consult their specialist for medical clearance if you feel it's appropriate.
Yes, absolutely.
Yeah, it said The 6 months after a heart attack, I think, was more for extensive dental treatment, but you can still get a regular dental cleaning.
Mm-hmm.
Yeah.
Absolutely.
Yeah. So, but I remember when we were in school, Heather, because we were in at the same time. Anna's really old.
Heather.
So hers might have been a little bit different. But I remember in school it was, it was 6
What about
months.
stents?
I have that.
Mm-hmm.
Okay. So since you're asking about stents and we're talking about the heart, let's just go into pre-med for heart conditions. Let's see. Pre-med for heart conditions, it can get a little complex, and I highly suggest, because I was reading through this and I was like, I don't even know what the hell this shit means. I highly suggest that if you have somebody with some sort of complex heart condition, to make sure that you get clearance from their cardiologist. However, that said, let's see, 2021 statement by the American Heart Association says that they recommend pre-med to prevent infective endocarditis only for categories of patient at highest risk of adverse outcome, while emphasizing the critical role of good health. So basically, when it comes to hearts, what I am to understand when I was reading this is that it's just a relatively small set of people who need this.
Yes.
And those people...
That's what I read.
Yeah. Those people are basically people who... what are you doing? Basically people who have any kind of non-human things in their heart.
Yeah,
so
like...
if they have a prosthetic valve.
Yes.
If they have a stent. If they have a prosthetic material used to repair a valve. If they have a history of endocarditis, of course.
Yes.
Cardiac transplants, and then there's some valve regurgitation. So basically anything fake in your heart that is not that you were not born with, and anything that has to do with a valve regurgitation, I would say play it safe, call a cardiologist, and get some med clearance.
Here's the thing, but stents don't require pre-med.
No, I just heard her say that.
Yeah, her med,
and you probably saw my eyes
don't
go like,
require
what?
pre-med, and
Hold on.
neither does mitral valve prolapse or regurgitation. That doesn't need pre-med either.
So unrepaired cyanotic congenital heart disease,
yes,
including palliative shunts and conduits.
Yes, that's
okay?
Congenital, yes.
But let's see. There was it was so confusing. Congenital heart disease present from birth, it said that there's no pre-med. But for unrepaired cyanotic congenital heart disease with palliative shunts and conduits, and then any repaired congenital heart defect with residual shunts or valvular regurgitation.
Yeah, congenital though, like I that's like the key word, I feel like.
Yes.
So like a stent placed does not need pre-med. Mitral prolapse regurgitation doesn't need pre-med. Heart murmur obviously doesn't need pre-med.
No.
Things like that. But yeah, so I mean it does get a little complex. Basically, from my understanding, the only things that really need pre-med as far as the heart goes is a valve replacement, congenital, non-repaired with shunts, like as you said, like when you're born with a hole in your heart and they put a shunt in to do, I don't know how that works, but whatever.
We are not doctors.
Yeah. But other than that, generally, that's it.
Yeah. So there's, people who have just had heart attacks and people who just have have treated heart disease and things like that.
Mm-hmm.
Like, no, it's just when you have some fake parts in there.
Absolutely. And then that leads us to the other, now let's go to the orthopedic side of pre-med, because this is a big one too.
Yes.
I
think this is one of the biggest ones. Like, why are you still doing that? And I think there are so many people, there's so many moving parts to this that, I mean, what is it? 2012? What is that? 12 years ago? And we're still talking about this?
I know. And it drives me nuts. And the problem is that the orthopedics and the Orthopedic Association, Dental Association completely agree. They both agree no pre-med isn't required for hip replacement, knee replacement in general, no. Unless there is a history of a previous prosthetic joint that was infected that needed to be replaced. That's different. But for some reason, the orthopedists that are out there are still not on board. They're not following their association. So they're saying pre-med is still needed. So in my office, if they want pre-med, they write the script. We're not giving it and we don't care. Like, you want that, you can write it. We're not writing a script for a pre-med that we don't feel is necessary according to our guidelines, right? So we've been doing that.
Is that your guideline for your entire corporation?
I don't know what my other offices do. I just know my my particular office. I guess it's probably up to the dentist, but in my particular office, if it's under 6 months, that it was done under 6 months ago, we will call the orthopedist and get a clearance. After that, we're not doing anything. We're just going straight in.
Is there a waiting period after a joint replacement to get your teeth cleaned?
Not that I could find.
Not that anything's set in stone, no. No. But if it's less than 6 months, we will call just to get clearance, because whatever. But after that, we don't even ask about it. We're doing, when they changed it with say, mitral valve prolapse, that was a huge thing back in the day. When that was changed, were you calling the cardiologist for everyone that had mitral valve prolapse to get clearance? No, you just stopped fucking asking about it and stopped pre-medding these patients. So why is it so hard to do that with this?
Because so many people are not, there's 4 people involved in this. There is the orthopedic surgeon, there's the dentist, there's us, and then there's the patient.
Yeah.
So we all have to be on the same page.
And that's the problem, is nobody is following the science and nobody's on the same page. But even if the orthopedist says, oh yeah, I want my patient pre-med, we say, okay, you're going to have to write that script for their life, because we're not going to be responsible for writing a unnecessary prescription. And that's what we've been doing. And you'll be shocked how many times when you put it back on them that now you have to write the script, they'll say, oh, well, only for a year or only for 6 months, or they'll change their tune because they don't want to be bothered. So,
At our office, we default to the orthopedic surgeon, and whatever they say is what we put in the patient's chart. And we see everything from pre-med for life. To pre-med for 2 years post joint replacement, and sometimes for 1 year post joint replacement.
And sometimes not at all.
Yes. Yeah. My office, I've encountered maybe 1 or 2 of those. What I do encounter, especially a lot lately, is patients that come in and when they actually tell me their updated medical history, oh yeah, I had like a knee replacement, hip replacement, blah, blah, blah. I'm like, oh, well, did you take a pre-med? Did they talk to you about a pre-med? Did they tell you, is there a waiting period? And they're like, nope.
Yep.
They didn't tell me anything. And that part frustrates me, because then I have to stop. I have to find out who their orthopedic surgeon is. We have to call their office, hope that they answer, hope that we get someone. And so it's hard.
Yeah.
I'm shocked at the number of people who don't know who their orthopedic surgeon or even what office.
I know, right?
You don't know who it was somewhere over on Allisonville. It's like, okay. So the ADA could not be more clear on their guidelines. It says, and this was, this took into account 2012 and then 2013. They went in with the orthopedic people, and it is, in general, this is a quote, in general, for patients with prosthetic joint implants, prophylactic antibiotics are not recommended prior to dental procedures to prevent prosthetic joint infection, period.
Yep.
That's what it says. In general, of course, there are exceptions. We're going to make exceptions for people who are medically complex. We are going to make exceptions to people who are immunocompromised. And we're going to make exceptions for people who've had, previous infections on their replaced joints.
Yep. And that's it. Simple as that.
Yeah, that's it.
What's one of the other subjects besides pre-med? Oh, pregnant patients. Let's talk about pregnant patients. This is all.
What do you
this
mean?
is all over the place. Like we have people that post like, oh, at a new patient pregnant in the first trimester, and she was mad that we wouldn't see her, and it's like, well, why didn't you see her? Oh, she's in the first trimester, and like outdated protocol. Let that pregnant patient get their damn teeth cleaned.
Yes,
you can take X-rays on your pregnant patients. It's okay.
And we know that periodontal disease, periodontal pathogens, periodontal bacteria has been linked to
low birth weight. Yep.
Yeah.
Mm-hmm.
And it premature birth or no?
Yeah. Premature
I would
birth, low
assume
birth
that
weight.
goes
Yeah.
hand in hand.
Yeah.
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 So, let's get these cardiac patients cleaned up and let's get these pregnant patients cleaned up. Get them healthy.
Absolutely. We have a new patient who's pregnant. We just have the OB just fax over a clearance just because that's like one of our corporate rules. We just want to have something on file. Never have I been told you can't take X-rays. I mean, come on. And if it's a new patient, I'm taking a full mouth series. I'm sorry. Like I've never seen you before, and that's our protocol for new patients. You being pregnant doesn't change that. It's perfectly safe, and there's no reason not to.
Yeah. So I guess I should say my little research for today was the new lead shielding recommendations.
Yeah. Mm-hmm.
Yeah. So this year, the American Dental Association, the American Academy of Oral and Maxillary Radiology had all say that the use of lead abdominal aprons and thyroid collars on patients when conducting dental x-rays is no longer recommended, according to an expert panel established by the American Dental Association Council on Scientific Affairs. So that was this year, like in February.
Mm-hmm. So that's going to be one that's going to take a while.
It's going to take a while. And so it says, published studies on radiography, the expert panel determined lead aprons and thyroid collars are no longer necessary to shield patients from radiation exposure. These recommendations apply to all patients, regardless of age or health or pregnancy.
Really?
Evidence
Even pregnancy?
indicates that even pregnancy. Evidence indicates that modern digital x-ray equipment and restricting the beam size only to the area that needs to be imaged better protect patients' radiation exposure to other parts of the body. Lead aprons and thyroid collars can also block the primary x-ray beam, preventing from capturing the image they need, and then you have to do retakes.
Yeah, I don't think that that's really a problem unless your thyroid collar is like way up here. I don't see how that would happen, but I did hear that
in panos. Yeah,
well,
panos,
as long as you don't use the thyroid collar for a pano, yes. But I heard that using a lead apron is actually, it traps the radiation.
The scatter. I heard that too,
but I haven't read that, so I don't know.
Like especially I have heard that.
Mm-hmm.
And I have just scoured the internet trying to find a study because I heard that the thyroid collar can actually trap scatter radiation, then causing like more damage.
More exposure, yeah.
Yeah, so I heard that, but I couldn't find that anywhere. I've looked and I've looked and I've looked and I could not find that.
I feel like I'm still going to shield my pregnant patients. I just kind of feel like I should. I don't know.
Why?
I don't know. I don't know. I just feel like I should.
You just sat on your hill.
I know.
You said you're going to do an FMX.
No, you can do an FMX, but I'm still going to shield them for that.
Do you have a digital x-ray?
Yeah, of course. Everyone has digital. Who doesn't have digital?
Okay.
People are so...
Do you have... Well, no one's supposed to have regular film. I think there was like a law that was passed years ago.
Yeah.
But, do you have like the square or the round?
I don't know. I don't take x-rays. It's my assistant that takes them. So I don't know if it's round or square. I don't know.
You do.
I think it's round. I want to say it's round. Our tube head is round.
Okay. Well, it should be, I think they're switching, saying it has to be more rectangular now for it, but still round is...
I didn't know that.
The beam is,
Yeah.
The beam, the what's it called? Caliber? Is that the name? I don't remember.
Molly B. Denham. That's the only thing I remember from radiology is Molly B. Denham.
Radiology sucked, dude.
Yes.
Oh my God, that was the worst.
So, but I do want to say before we go off is these are guidelines. Every state has its own laws.
Yes. So
I am here in Indiana. Liz is in Indiana.
Yeah.
And I just went to a CE with Jay Gielich or whatever. He's like the ethics guy from the ADA. And in the state of Indiana, you still have to put a lead apron on your patient.
yes.
Really?
Yeah. Same in Texas, I believe, from what I hear.
I didn't know that about it.
Yeah.
I don't know about New York.
Yes.
I don't. I haven't seen.
I tried to look up New York.
Couldn't
Do you
find it.
even have a dental board?
Yes, we do.
I couldn't find it.
Yes, we do. But we still use a lead apron. I know this is new and old. This is part of old habits die hard. But I think if we don't, patients are going to be like, "What are you doing?" They're already
That's it.
paranoid about the X-rays
So
to
that-
begin with. Like, let's not.
Yep, that's the whole
So
thing.
that is what Jay said in, first of all, you have to go state by state. It is on the docket for the ADA, the Indiana ADA, to discuss in their next sessions or whatever it is. But even though if they pass it, it has to go through House and Senate, and I don't know how all that works. And even if it does pass, then you have to do the patient barrier, because patients are like, oh my God, already they fight us to get x-rays.
Yes.
I have so many patients that are like, no. And now we're going to say, oh, you don't need the lead apron. So he's like, don't go throwing out all your lead aprons.
No.
But Indiana still requires protection of 0.5 millimeter lead equivalent protection during radiographic exposure.
Okay.
Yeah.
Some key takeaways, it says, recommendations from reputable sources have changed and are recommending no shielding with proper technique and equipment. So that's the key. You have to have the proper technique and equipment. Research is continuing and still ongoing. Guidelines from the ADA, state health departments, school curriculum will all need to undergo review. And patient expectations and education take time to change.
That's going to be the biggest barrier.
Yep.
It really is.
Yep.
And I have a patient.
It will.
I actually have two patients who are radiology techs. I don't know if that's the right name, and I'm sorry. And I have an actual radiologist, and they both said that they have also changed their guidelines. So it's not just dental. It's kind of across the board with just changing X-ray technology.
Yep.
Yeah.
Is what I'm understanding.
So, and of course you have to use ALARA. So,
Yeah.
What's that? No, I'm only kidding.
Yeah.
I'm kidding. Is that a name? Is that your patient's name, Alara?
that's a beautiful
my patient's name.
That's a beautiful
Alara.
name.
Anything else? We're
Sounds
at.
like ALARA.
Do we have anything? This could be a part 2 because there is such.
Yeah, we
there's
could
a
do
lot
part
of
2.
stuff that a lot of people are still doing, like not using their Cavitron, but
Yeah.
that could be another episode.
Cold sterile. Why are you doing that?
Cold sterile, other things, but
Why
that
are
could
you
be
still doing that?
a part 2 for us because there's a lot of things that a lot of hygienists still do that is outdated. So
Yeah, I think we're definitely going to have a part 2.
yeah,
Because we haven't touched on half the stuff that we normally do.
yeah.
So, yeah, stay tuned.
Thank you for joining us again. I feel like we kind of flew through some information. We're
I know.
usually pretty chatty bitches. Anyway, thanks for joining us. As always, if you have any ideas about topics we could cover, things that you would like us to cover, please slide into our DMs and let us know. You can find us on Facebook at RDH RANT. It is a private group. You have to be a hygienist to join. Sorry, we do verify your license to let you in. You can follow us publicly on Instagram and also on TikTok. And anybody can join those. Anybody can watch our shenanigans there. So anyway, Anna's
Join
losing her
for
mind.
you.
She's got something a suction to her forehead.
Stuck to her forehead. You're going to have a big hickey.
We've got to do videos sometime.
I know.
Anyway,
I keep
it's time for us to sign off. Time for you to floss off. Love,
Floss
peace,
off.
and brush your teeth.
Bye.
Brush your teeth.
Bye. Bye.